Welcome to More Than Miles, the podcast where we use storytelling and expert interviews to widen the lens on what it means to be a happy and healthy endurance athlete. We believe that athletes are so much more than their body, sport, and training miles. I'm Dr. Kate Mihevik-Edwards.
And I'm Dr. Kacy Sinders. We are endurance athletes, physical therapists, and huge coffee addicts. We spend most of our time treating, educating, and working with endurance athletes. Thank you so much for tuning in today. Now let's get to the show.
All right. Hello, everyone. Welcome back to More Than Miles. I say welcome back because this is our first episode that we are recording in 2022. So happy New Year to everyone out there, even though this is going to be quite belated once you get to this episode. But for us, it is our first episode of the new year, and we're really excited. We're going to talk about Achilles pain. What is it? How do you treat it? It's one of those really pesky injuries, and it plagues a lot of runners. So we thought that it would be a really good episode to dive deep and really dig into what to do if you have Achilles pain. So, Kate, first, though, I want to know, do you have any New Year's resolutions?
I don't do resolutions. And so the reason I don't do resolutions is because I often can't stick with them. So what I try to do is just make small changes throughout the year. So I'm a daily meditator, as you know. My plan is that I'll try not to miss many meditations. I had a few weeks where I was not really sticking to it. So that's the best thing I can say. It's closest to the resolution I have. How about you?
Yeah, I don't do resolutions either. I usually do a word, and I've actually kind of struggled with picking a word to build on a theme for this year. Last year it was courage, which I think was really a good one. And I kind of wanted to stick with it because I realized that a lot of the things that I struggle with are out of fear, like most of us. But I think this year I'll pick joy.
Oh, that's a good one.
And just protecting and choosing joy. Because I think if you come back to that, you can get through almost anything. That's where I'm going to focus my energy this year. But I do have a big goal of getting better at public speaking, which is kind of ironic because I don't think we're still going to be doing a ton of public speaking with the state of the world and everything. But, you know, I think if you're a good speaker in general, I'm trying to work on my eloquence. I tend to just spit emotion all the time, which is great sometimes, but other times it's not. So I would really like to get better at that.
I think we all need to continue to get better at that. I do public speaking and, you know, I speak in front of hundreds of people, but I still think that I could do a better job. And I often spew emotion, but I think that's what makes me good at it. So maybe spewing emotion really isn't the problem, Kacy.
For the record, I think you're very good at public speaking. And I'm always in awe when I listen to you speak.
Oh, thank you. Well, I wasn't looking for a compliment, but thank you very much. I'm glad you said that because now I'll think of things that I can rope you in on.
Oh, no, that's good. This is what I needed. You have to say yes to the opportunities and practice. I'm like really trying to get repetitions and practice and say yes to things that even though they scare me. That's where we're at.
That's a good thing. And I love your word joy. I actually do intentions every day before my day starts. And usually happiness and joy are in there somewhere. So that's cool.
Love it.
All right. So let's get down.
Joyous note.
On that joyous note. Let's get down and dirty with the Achilles.
Okay. So a great place to start here, right, is with the relevant anatomy. So what is pertinent when we're looking at Achilles pain? What's in the region? This is kind of how we learn as physical therapists. We always start with the anatomy, and then we can work our way towards the diagnosis and the symptoms that the patient is having. So the Achilles tendon is the largest tendon in the body. Most of us can feel that. It's a big tendon back there. And it's really important. It's our spring, really. It's our Tigger spring, as I like to call it sometimes, as we're jumping from one foot to the other as runners. And so the Achilles tendon is made up of two muscles, actually. It's the gastroc and the soleus, or gastrocnemius, if we're being technical here. So our two calf muscles, and they join to form a common tendon that attaches on the calcaneus, or the heel bone. The other really interesting thing to note here is that all tendons are a substance called fascia, or this really thick connective tissue. And so when our Achilles attaches to the heel, it keeps going. It's continuous into the plantar fascia. And most runners know that plantar fasciitis is a bear of an injury as well. And so this is why a lot of times when you have Achilles and plantar fasciitis kind of issues, or plantar fascia issues rather, we're targeting the calf muscles a lot for treatment because it's all one continuous unit and they really play on each other. The other thing we need to know is what does the calf do and the calf complex do when we run. I've talked about it as our spring, which is absolutely true. But the other thing we really should note here is that in mid-stance, when that foot is passing right underneath the body, so think about the down step, if you're familiar with down step photos on Instagram, that's when the soleus is most active, and it stabilizes from our shin bone or tibia from coming forward. And so that's a big muscle contraction. So you think about that over and over and over again. This is where sometimes we can get that excessive stress on that muscle tendon complex. And then our gastroc, or what most of us think is like the meaty part of the calf, is what's active and push off and what actually propels us forward. So a little bit of relative anatomy there. Anything that you want to add to that, Kate?
I thought that was pretty good. The only thing I would say is that the soleus is more of an eccentric exercise. So like as you're in mid stance and moving to push off, because it's stabilizing the tibia, the soleus is working eccentrically. So it's elongating. And then the gastroc is working concentrically, and that's the push off. So it's the power. The gastroc is the power and the soleus is the stability. And so both of them making up the Achilles tendon, either of those actions can cause some Achilles tendon issues. But if you're thinking about how you're exercising, what you're having trouble with, one or the other might be more inclined to kick the issue off with your Achilles. So it's just something as runners we probably need to know. And then also you talk about the spring, but what you're really saying is that all tendons act as a spring. So as you hit the ground and you load the foot and the lower extremity, all the energy is being stored in the tendon. And then through push off, it's being let go. And then if you're having any issues with the tendon, then you can't store energy very well. And if you can't store energy very well, then you become a much less efficient runner because you can't really use the power.
Mm-hmm. Yeah. And we'll get to this later on in the podcast when we talk about treatment and what does exercise look like and specific exercise for specific types of Achilles issues. And as well as, the whole crux of recovering from an Achilles issue or Achilles pain is restoring that ability to store and release energy properly. And the other thing, another cool anecdote to add in here is, if you're running, whether you're on the treadmill or outside, and you can kind of listen to the sound of your footsteps on the side where you have your problem, it's going to be louder because you're not able to spring off the ground as well. Just a little bit of an anecdote, not necessarily instructional by any means, but just a good kind of example of what happens when we lose that elasticity of the tendon.
Yeah, that's great. That's one of those things when we're listening to somebody on the treadmill, we close our eyes and you can hear it. So one of the things that we should really talk about too is what are symptoms of an Achilles pain, either, and we'll talk about a tendinopathy, tendinitis, all of that in just a moment. But when you really have Achilles issues, there are a certain set of symptoms that will show up. And so that's swelling around the area of the tendon. It can show up looking like a nodule, actually like a bigger bump on the tendon itself. You'll notice that you have weakness with push off during running or going up the stairs because you have to rise up on your heel. You'll have some joint stiffness. You'll also have pain with use of the muscle. So again, with push off or walking up and down the stairs, you might notice some cracking or popping. It'll be painful to palpation. So if we touch the tendon, we move our hand up and down, kind of pinching at it, there will be pain there. You also might notice some tightness in the calf muscle itself, all the way up into maybe the back of the knee or even down into the plantar fascia or the plantar surface, which is the bottom of the foot. So you might find tightness in all of those areas. Your great toe might not feel like it can move as much. And really, you might end up with some tightness all the way up the back of the posterior chain of the body because of the fascial attachments.
Yeah, I'll often hear runners describe it as like a band-like feeling, and that's kind of that stiffness of the tendon. So if we think about the difference between like a muscle tightness, if you go to stretch your calf and it feels tight versus an actual issue developing in a tendon, sometimes they'll get that kind of like band or straw kind of like feeling. And typically it'll be worse in the morning or after a period of inactivity. So people will report that it's the tightest when they wake up in the morning and they're kind of hobbling around for a bit. Or if they're working from home and they, stand up at the end of the day, they'll notice it then as well. So we should get into, because there's a lot of terminology here, and there are scientific definitions of each type or of each category of Achilles problem. I do want to go through the technical definitions, but then also really what does this mean from a treatment standpoint?
I'll describe the tendinosis versus tendinitis first, because I think people get a little bit confused about that. A tendinitis is acute inflammation in the area of the tendon. And so it occurs with multiple micro tears in the tissue itself over time. And then a tendinosis is actually chronic deformation or change in the collagen in the tendon. So we have different types of collagen. And with a tendinosis, what happens is that collagen is breaking down, because what we're doing is it cannot keep up with what the exercise that we're going through or the load that we're putting on it. And then if it can't keep up, then that's where it gets torn. That's where we start to have pain and issues. And then when it starts to heal, what happens is the collagen will lay down trying to heal, but then it'll lay down in a disordered pattern. So it won't lay down in this kind of parallel line pattern, which it needs to be strong. And so then it becomes weaker. So that's really the difference. It's an acute inflammation versus a chronic deformation of the collagen itself.
Mm-hmm. And we can put tendinopathy in the tendinosis category as well. Relatively interchangeable. There are some physiological differences, but I don't know if it's super important for us to get into that here.
I think tendinopathy is a catch-all term too. I think a lot of people just use tendinopathy for everything. So you have to be careful that you're just not using that term and that you're really differentiating between an itis and a nosis.
So what does this look like from a practical standpoint? A tendinitis is more of an acute issue. So let's say maybe you go for a long run, maybe there's more hills than normal, or it's faster than normal or something like that. And your Achilles feels like what we call kind of hot, right? Like it feels inflamed in a way. There might be some swelling, but prior to this, you were having no issues to your Achilles. So that would be more a tendinitis issue. And so how we would take that more with our traditional rest. I don't want to go through the whole rice thing because I don't think that's 100% the route we would want to go there, but we need to treat it as an acute injury versus a tendinosis or tendinopathy, which is something where it kind of comes on gradually. You start to notice tightness and it just gets tighter and tighter. And maybe it feels better some days, worse other days. And this is more of a longer duration problem, more of a chronic issue. So the treatment for that is going to be a little bit different. And we will get into that a little bit later. But I think a lot of people have a hard time differentiating between the two because they both involve Achilles pain and they both involve some sort of swelling or nodule. But the duration is sort of the key differentiator there.
Well, and I think the other thing that we have to remember is a lot of people will say, well, it might not be my tendon because I can run fine. Once I get started, I'm totally fine. It's just before I run and after I run. Well, the issue is whenever there's a tendon or a tendinopathy issue, it always feels better when there's increased blood flow and you're moving. And it doesn't mean that what you're doing isn't damaging it or making it worse. So we do have to say that out loud because a lot of people will say, well, if I could just get through the morning and then I do my 10 miles or my 5 miles or even 20 miles on it, I'm totally fine. But, the next morning when I wake up, I can't really walk, but it's okay because then once I start moving, I can go out and run again. It doesn't mean that you can't run. It just means that we might have to modify how you do it and then also treat out the tendinopathy.
I'm really glad you brought that up because that's something I see often too. And whenever I occasionally give injury prevention presentations for different organizations. And something I always like to include are like yellow flags or injury warning signs, and stiffness that improves with running is one of the biggest ones because people ignore it all the time. And like you said, it requires some treatment, it requires some modification, but if you don't do anything at all, it's just going to keep getting worse and it's going to get you to stop at some point. So we have to respect it and see it as a warning sign, even though you can run 20 miles with it, right? If you can't walk at any point during your day because of a running injury, you should probably do something about it.
Yeah, I'm with you right there. But I can't remember what the statistics are. Usually I'm really good with statistics, but at the top of my head, I don't remember. But it's some shocking number of people who never will seek medical attention, even if they can't walk. And I think that our population, runners, triathletes, we are very high in that group. We will do whatever we can to keep running, even if we can't walk for as long as possible. And that's not
walking isn't important. Running's the only thing that matters.
Right. I know it doesn't count walking, right? But I think it's good to say, why don't you get this taken care of earlier so that it doesn't interrupt your training? It doesn't become a long-term issue. Because if you have a tendinitis and you don't clear it, then you might end up with a tendinosis, which is a lot longer in terms of treatment. And it takes a really long time and it's very frustrating. or it can be for some people. So if you have something showing up, take care of it early is really the key there. Okay. So let's move on a little bit. Something I like to always talk about when we're talking about any kind of specific injury is what else could it be, right? So when we, as PTs, what we do is something called differential diagnosis. And so when someone comes in with an issue, we look at all of the other possible things that it could be, and we rule them out so that we can make sure that our treatment is very specific and we're treating the right thing. And so there are a lot of different things that can come up that might act like an Achilles tendinopathy or tendinitis, or at least show up a little bit like it. They can be things in your lumbar spine. So you could have like a lumbar radiculopathy, which is symptoms that are coming from your lumbar spine or your back that show up in your foot and your ankle. You can have some nerve irritation. I actually find that the sural nerve, you can get some irritation in that nerve, even if you have a tendinopathy or a tendinitis. Sometimes they come together. So if you're getting treated for a tendon issue or an Achilles issue and it's not resolving, it might be worth looking into that sural nerve component to see if that's just something that's adding to it or if that's the real driver. Sometimes it's a stress fracture, like a calcaneal stress fracture, and it's showing up in that area. There's retrocalcaneal bursitis that might show up there, posterior ankle impingement. Go ahead, Kacy, tell me the Oz, because every time I say this, I say it incorrectly, but
Os trigonum. Os trigonum, yes. An extra bone that's on the talus, which is one of the bones that is part of the ankle, foot and ankle complex. It creates a pinching with forced plantar flexion or pointing your toes forward. And often posterior ankle impingement and os trigonum go together because it is that extra bone that's causing the impingement there.
Right. And also that plantar flexion or that pointing of your ankle. So that forced plantar flexion will show up with both. I always call it os trigonome.
I mean, I guess because of the way it's spelled, I think that's a reasonable way to attempt to pronounce it. But it's more fun if you say it in an English accent. You go, os trigonum.
Os trigonum. That is funnier. That is better. Okay. So those are definitely some of the things that should be looked at if you're coming in with any Achilles or tendon pain, just to make sure they're ruled out or to see if they're adding to the issue. And you'd be surprised how many times a sural nerve or a lumbar spine issue shows up with an Achilles problem, especially if it's a really long-term problem, because when you can't push off the foot very well, then you start to lose hip extension and then you start to go into your back a little bit more. They all kind of end up working together and working against you, really, if you don't start to address it early.
Mm-hmm. Yeah. And a lot of these things are layered in that way. And, this is what a lot of runners know. Compensation is an issue when you have some sort of pain or dysfunction in some area of the body. But sometimes it's hard to know the nuances of it. And the lumbar spine is definitely something that takes a beating when our mechanics are off. And it's often missed in the healthcare because they're just like, oh, you have an Achilles problem. And if we don't address those other pieces, it could end up taking a lot longer to resolve than theoretically it should from a prognosis standpoint.
That's right. So why do people get this? What happens? I think this is another good topic or idea to bring up so that people can understand, how did I get this in the first place? What are the risks?
Sure. So there's a lot of them. And, there's overlapping risks for a lot of different types of injuries. But there are some very specific things that I know that we both look at when we see someone coming in with an Achilles problem. One of the main ones being poor control or late pronation. So this is a foot and ankle issue. So I'm going to kind of work from my bottom up because obviously a lumbar spine, everything is involved here. But if we look at just what can go on at the foot, when our foot goes into pronation, it's a multi-plane movement, meaning that in a very, very simple terms, there's some sort of twisting that goes on or some sort of multi-plane movement to where it's not a linear load on the tissues through there. So if we can't control that pronation and that inward movement of the foot, the Achilles tendon actually gets wrung out a little bit. There's more load in a direction that the Achilles isn't meant to handle. And so it can cause over time that disorganization of the collagen and of the tendon fibers themselves. And over time that creates that nodule that we were talking about earlier. So poor control of pronation, meaning that it happens too quickly and your tendon isn't able to dissipate that load fast enough. Or late pronation, where we see it a lot later in the gait cycle than we normally do. And so what this looks like is when you push off and your foot is still kind of diving inward into that pronated position. And so one thing I actually do when I see people in the clinic for this is I show them sort of the orientation of their tendon at push off. And you can see that it's not straight up and down, but it's angled a bit. That's a pretty tangible and easy visual to look at. They're like, okay, the Achilles isn't supposed to handle load in that position. So those are big things that we see at the foot and ankle. Again, kind of keeping with the strength and the runner itself. We'll talk about kind of extrinsic or external factors here in a second. If you have limited ankle mobility, this is ankle dorsiflexion, right? So a lot of people think of this as pulling your toes up, if you want to think of it that way. So it's ankle mobility and that ability for you to get your toes up. And so on the ground, what that looks like is bringing your shin bone over that foot. Now, we need a specific amount of this or a sufficient amount of this so that we can get over that foot. Our hip can go into extension. We can actually turn on that glute and push with both the calf and the glute into hip extension. What happens for a lot of people who have limited ankle dorsiflexion is because you can't really get past that ankle piece of it. You have to push off with your calf a little bit early, meaning that you're pushing so much more with your calf has to work a lot more because you can't even use your glute to help out. Backtracking just a little bit. So if we look at great toe extension as well, so our great toe, right, our big toe, very pesky and important little joint there. If we don't have enough extension through that toe, then the plantar fascia can get stuck on the plantar surface of the foot. And so that's going to make it so that it kind of, as that fascial connection goes up through the Achilles tendon to the calf, it can cause sort of a tightening of that whole sort of posterior chain of the leg as well. So we have to have good mobility into roughly into good an extension of the toe, ankle, and hip. So Kate, I'll toss it over to you to talk about more extrinsic factors there.
Sure. And so I actually love what you said about looking at gait, because this is something that we talk about. And whenever I'm teaching gait analysis, I really like to point out about Achilles problems is that people who are really pushing a lot through the calf and the foot and not using their hip are really at high risk for getting this Achilles issue, just because it's overloading every single time you take a step. And it's really easy to see on gait analysis, and it's really easy to hear, like we mentioned earlier. But some of the other risks for an Achilles issue that have to do with training and that aren't really to do with your joints and your muscles are things that we can control. So rapid changes in training surface, speed, or amount of training. So this all comes back to your knowledge and your ability to kind of manage your training schedule, right? So if in the new year you've decided that all of a sudden you're going to train for a marathon, I say that's a great thing. I also say, take it slow. So if you've never done it before, take it slow, because you could end up with one of these injuries. We see this all the time, especially at the beginning of the year, because if you're really quickly loading a tissue that's not used to being loaded in that way, then there's going to be breakdown because your loading is exceeding its ability to heal and repair. And so that's what happens when you start to change surfaces really quick. You start to increase speed very quickly, or you start to increase the amount of training in miles that you're doing. And then people often wonder about the speed factor. Why is that an issue? Well, as we get faster, our mechanics change. And so if we have a lot of weakness or we have poor movement patterns, then it shows up more the faster that we get. So we also have to slowly increase our speed as we're getting stronger over time. Other things that kind of add to this are, unfortunately, age. So I was thinking age 40 to 60. I'm like, wow, 40 to 60, that's kind of old. Well, I'm in that age range now, so that's awesome. Kacy's not even 30 yet, just so you know. And we were just talking about this earlier, but if you're in that age range, you're actually higher risk for some kind of tendinopathy. So there's decreased blood flow to the tendon. And then something that also comes up is that certain antibiotics are making you more prone to a tendinopathy. And I don't think people really use Cipro that much anymore, but that's definitely one of them. In my long career of treating athletes, have seen several tendinopathies that were caused because of antibiotics, and they definitely do not recover as well, and they take a lot longer. And I found that they don't necessarily respond to the same types of treatment that other tendinopathies respond to. So you have to be a little bit more creative when it comes to a tendinopathy that's caused because of an antibiotic. And then I think also you touched upon like poor utilization of the calf and the glute, or the glute utilization and more utilization of the calf. But those are the big things, I think.
Mm-hmm. Yeah, I have actually a fun story about this. I always have a story. Oh no. That's not the reaction I was hoping for. So in December, I ran a marathon out in California and woke up the next morning. My quads were pretty sore, typical post-marathon, total body fatigue, right? But in terms of pain and discomfort, it was mostly my quads that were very sore. And I had planned to tack on a trip to San Francisco afterwards. For anyone who's been to San Francisco or has ever thought of going to San Francisco, it's a very hilly city. And so I'm in San Francisco. I don't know when I'm going to get back on the West Coast. I'm incredibly sore, but I'm like, Kacy, you are walking your butt up and down these hills and you're going to see everything you want to see. I don't care how tired you are. Day after my marathon, I walked 10 miles around San Francisco. Do not recommend it as a recovery technique. I knew what I was doing in inhibiting my recovery, but I was on vacation. I was going to do this. I have no regrets. I honestly have no regrets.
It was really fun. I know.
It was. So I wake up the next morning. So this is 2 days after my marathon, and my calves are killing me because I had walked up and down the hills without using my quads or my glutes. And so it was all my calves, and it was all eccentric going downhill, trying to control my body because my quads weren't helping me out. And so I created a new problem for myself, but I just thought it was really interesting because my calves were completely fine after the race. But it was the day after, once I walked 10 miles around San Francisco, that my calves were killing me.
So basically what you're saying is when the rest of your body is not functioning, we start to compensate and use other components of our body, like our calf muscles, that could put us at risk for a tendinitis or tendinopathy down the road.
That's right. Yes, yeah. That's exactly what I'm saying.
Well, things are going to happen. People are going to do what they want to do. And I probably would have done the same thing. I'm just giving you a little crap.
No, that's fine. I knew what I was doing. And I was actually pretty mad. I got back to Atlanta and I was still really sore. I'm like, dang it. Why did I have to do that? Because it did. It took a little bit longer to recover, but this life is all about experiences and it was a good experience. So.
Well, that's good. Okay, so let's bring it back to treatment. So we've kind of gone through what causes Achilles issues, what they are, some of the anatomy, what it could be if it's not an Achilles issue. And let's now start talking about treatment, because oftentimes people want to say, okay, so I have this thing. I know what it is. What am I going to do about it? There are a lot of different things that we can do. And most people want it to be over with sooner than it really can be. And one of the things we're going to talk about is that, unfortunately, one of the major things that we do, eccentric exercise for this type of issue, it takes a lot longer. It takes probably 8 to 10 weeks of really consistent work before you see results.
Yeah, I can't tell you how many times people come in with a chronic Achilles thing. I'm like, oh yeah, I tried the eccentric thing and it didn't work. And of course I dig into some more details, and they had done heel raises for a week or two, which is not enough. We're not going to see a big difference there. There's a lot of research on this, and eccentric loading, or that lengthening sort of portion of a heel raise, is what helps us to realign those collagen fibers and those tendon fibers into that linear fashion again. So if you think about that bump that you might have on your tendon, the way to get that to remodel itself is to load it in the right way. The other thing I see a lot too is, so it's not just going through the motions and doing a ton of heel raises. You have to do them correctly and with proper foot posture, right? So a lot of people, especially people, so with poor dorsiflexion, so if you don't have ankle mobility, a lot of times we'll put people on like a step or something like that to work on range of motion. And once we exceed their available ankle dorsiflexion, they're going to start to compensate through their midfoot and go into that position where we get tendon, the wringing out of the tendon that we were talking about earlier. So the two things when people say, oh, the heel raises didn't work for me, it's either they didn't do it long enough or they kept wringing out their tendon as they were doing their heel raises, and we never got that relative rest and remodeling that we really needed.
Yeah. So what you're really talking about is that when somebody's coming up, like raising up onto their toes and lifting that heel off the ground and then slowly coming back down, what we should see is complete control. And you shouldn't see, if you're looking at them from behind, there shouldn't be a lot of wobbling in that heel. There shouldn't be a lot of movement in the foot, because when there's movement in the foot through the midfoot and then there's a lot of wobbling in the heel, that's where the wringing out occurs. And we really have to make sure that we keep them in a range where they can control and then slowly increase that range. And that's why a lot of times we have people start with 2 feet on the floor so that they're not dropping down too far. And then we move them to 1 foot so that they can control it better. And then you move to a higher surface. And a lot of times, depending on the person, I may not even have them go off of a step for a while because they really can't control their foot in single leg stance. And also if they have a lot of symptoms, I don't like it because I don't like them to pinch that tendon as they lower down.
Yeah, that's right. Thank you for elaborating. That's what I was trying to get to. And that's the important thing of having a rehab professional or someone help you, right? Because if you read a Runner's World, not to pick on Runner's World, but if you read an article somewhere on the internet or watch a video about heel raises and you just generically start doing heel raises, it seems very simple, but there are a lot of nuances here. And to have someone watch that graded load and make sure that you're doing an appropriate range, an appropriate amount, and who can monitor your symptoms, that's what's ultimately going to lead to success in the long run.
That's right.
Love that long run pun.
Long run. I'm just kidding. But no, that's true. And then you might even add weight. And I mean, it can get pretty difficult. And in the beginning, it's hard because it feels boring and you don't see results very quickly when it comes to like a tendinopathy. And so it's very hard for people to hang on. But if they do, then they're going to really see the benefits. And then other things that add to that. So we don't just do eccentric loading and heel raises. I want to make sure that we continue on this path because there's so much more than that. So in our clinic, we do a lot of manual therapy. So we'll address the foot, the great toe, the ankle, the calf, the hamstring, the sural nerve, the glutes, all the way up into the back, sometimes even into the thoracic spine, to make sure that you can really extend through that hip and really move through that entire line while you're running and working through single leg exercise. So the manual therapy component is huge just to get the movement patterns down. But then you move from the manual therapy and you'll start doing more functional exercise, not just heel raises, to get those patterns to keep going. Sometimes rolling patterns, lots of squatting, single leg activity. And then we add blood flow restriction training as well to a lot of these athletes, which is really cool. And if you haven't really done blood flow restriction training or not sure what it is, or BFR, that's what everyone calls it, it's a cool name. What we're doing is we're really creating stress in 2 ways. So we're creating this metabolic stress through venous occlusion. And then we're also creating this mechanical stress through low load exercise. And what we do is we create this environment, we call it the hypoxic environment, to increase anabolic metabolism. And so basically, we put a blood pressure cuff around the area of the leg, high up near the groin when we're working on the leg. And we occlude it by pumping up the pressure at a safe pressure. And we have this great device where it actually monitors your blood flow so that it's really safe. And then you do the exercise while you have that blood pressure cuff on your leg. You want to go into that a little bit further? You said that you could say it in a way that people would understand.
Yeah, of course. So the way I talk about this in the simplest terms I possibly can is that it allows us to stimulate high intensity exercise without the intensity or without the load, right? So really easy way for some people to conceptualize this is if you were to do like a body weight squat versus, let's say, a squat with 100 pounds on your back. This isn't an exact calculation, but when we do the blood flow restriction training, so when we put the cuff around there and restrict the blood flow to the limb, we're mimicking that squat with 100 pounds without the 100 pounds. So we're able to create a stimulus for the body to remodel and change without actually stressing out the tissues itself. And so this is why it's great in a rehab setting and why it's great for people who have tendon issues, specifically tendon muscle issues, and then also post-operatively, so post-surgically as well.
Yeah, it is really great because you can get a lot more benefit early on by using this instead of waiting to when you can really load the tissue with high weights and loads. So this is nice. And it makes it easier to load somebody later because you've done this from the beginning. And then just a fun fact, as I was telling Kacy earlier, because I have random facts in my head, is that blood flow restriction training was actually created in the 70s in Japan, which I thought was really interesting because I didn't know where it was from. I read that in some research article probably last year.
Yeah, it's fascinating. I mean, that was so scary to say, but it's like 50 years ago.
Ooh, yeah, it was, wasn't it?
And we're just now seeing a lot of it now. And there's a lot of research being done, and it's being used a lot more in a lot more settings, which is great. So the other thing we have to address or look at, right, is shoe wear, or how is someone setting up their footwear when they have an Achilles problem. And something we didn't really talk about in the extrinsic factors that I think is worth noting is a rapid change in type of shoe. And I think that this is more of a dramatic, not like I went from wearing Saucony to Mizuno or something like that. I mean, certainly we can see issues there, but the biggest thing I look at is a big change in type of shoe. So like heel to toe drop, things like that. So if you go from usually having a 10 millimeter drop between your heel and forefoot, and you go to a 0 drop shoe, for example, that's something where we could definitely see something like this pop up.
It actually happens quite a bit because if you think about it, you have a wedge in your foot. You can think of a wedge underneath your heel with a 10 millimeter drop. And then you take that wedge out completely with a 0 millimeter drop. And so that tendon has to accommodate for that drop. And it's not used to stretching that far and loading in that range anymore. And so it actually happens quite a bit with that type of change in a shoe. So
we've got to look at the shoe, if there's any inserts or orthotics, and kind of look at what variables can we do to help manage load on that tendon. Because really the name of the game in rehabbing any sort of tendon issue, and specifically Achilles tendon issue, is managing relative rest with graded load. We need to find the right balance of that in order to get this sort of linear improvement in symptoms, improvement in strength. Because if we do too much load, we're going to go back to the beginning and take 3 or 4 steps back. And if we rest too much, or not rest too much, but if it's only rest, we're not going to actually build up the resiliency in that tendon so you can go back and run and jump and play and all the fun things, right? So what we need to do through shoe wear is figure out how can we manage load on that tendon. So maybe this is temporarily using some sort of orthotic or taping method to keep that foot in a good position so that we're not wringing out that tendon as much. Even just if you're not running that much, but walking. So any type of offloading you can get on the tendon. I know sometimes in more chronic or even in acute situations, sometimes they'll put a heel lift in the shoe just temporarily, very temporarily, because it can definitely cause a problem if you're in a boot or a heel lift type situation for a long time. But that can help put that foot into a little bit of or it can help shorten the Achilles tendon so you're not putting it on stretch as much, and can facilitate that healing process that needs to happen.
Well, and some of those heel lifts that we use are really cool because you can pull away layers of it over time, which is what I really like. So if someone is very flared up, I might put a heel lift in their shoe and say, okay, this week we're going to keep it at this level. And then next week we'll pull it down and drop it down. So you can slowly drop it down as their acuity changes. Yeah. Mm-hmm. Which is really helpful. And it also, and the truth is you can't exercise and strengthen it if you're in a lot of pain. So most people won't do the work if they're hurting a lot. And so that sometimes that heel lift will help just so that we can get the right amount of loading in the right range so that it can heal and we can take it out. Just really good.
Yeah. And Kate, I'll be interested to see how you usually advise patients on cross training when they're injured with Achilles pain. Because again, we have to manage the load. And so if someone's doing cross training that's loading the Achilles tendon too much, that could really interfere with the whole process that we're trying to facilitate here. So for me, it's always watching symptoms, but I really like people to go low impact or something like swimming or aqua jogging, something like that in the very beginning, just depending on how they progress, but for a week or two, or maybe sometimes longer before going to like the elliptical or cycling, just because there still can be a lot of stress on that calf complex. So that's what I usually say. What do you usually tell patients?
Yeah, I love swimming with an Achilles issue because a lot of people with cycling or the elliptical, they don't realize it, but they're really pushing quite a bit. And depending on your position, your foot position on the pedal, you could be driving a lot with that Achilles and not realizing it instead of keeping your foot flat. If somebody really can only do a bike, I'll say, fine. It has to be really low load, not Peloton, nothing like that. It's really just spinning it out and making sure that your foot stays flat on the pedal and that your toes are not dropping down every time you push down. Because if you're plantar flexing and your toes are dropping down every time, then you're actually aggravating the Achilles. The other thing I would say is, I'm a huge fan of yoga, but a lot of times the positions in yoga can aggravate the Achilles as well, especially, like downward dog where you're really stretching out the Achilles. So it just depends on where you are in the rehab. You can do that a little bit later, but the first few weeks, I wouldn't do that just because we're really trying to calm it down at the same time we're trying to load it.
Mm-hmm. Yeah, that's great. Because I don't think people really think about yoga as being stressful at all to the body. Definitely can be in certain situations. So I'm really glad that you brought that up. I think we're close to wrapping up here. We have mentioned a little bit about prognosis and timetable and what people should expect in terms of recovery. Of course, this is assuming that everything goes well. We take 2 steps forward, 1 step back through rehab. There's no complicating factors, things like that. I would definitely take a longer term approach with most of these. Of course, if it's just an acute tendinitis and you're able to rest it sufficiently to where it doesn't progress into more of a tendinopathy or tendinosis. We might have a little bit of a shorter prognosis for that. But I would say, 8 to 10 to 12 weeks or so before we get that complete resolution, you're able to at least start increasing training and increasing load.
I think you should be careful with the idea of complete resolution. So you said it probably won't be complete resolution at 12 weeks, but it'll be a point where you can start training again and adding load. Sure. And you probably will have symptoms for quite a while, but they should be decreasing over time. The other thing is if this doesn't work, right, in the beginning, if conservative treatment doesn't work, there are a lot of other things that we can start to think about and talk about. And I'd love to get your opinion on some of this, but some of the docs do PRP. There's amnio, which is more like stem cell that can go into the tendon. And then also 10X, which is a procedure that we've seen done on the tendon. Those 3 things can be helpful. And then also, we didn't bring up the idea of a Haglund's deformity, but sometimes if somebody has an Achilles issue and we realize that they have a Haglund's deformity as well, that could be driving some of the aggravation behind the tendon. And so those are some things that might have to be considered medically if conservative treatment isn't working.
Yeah, so people might have heard of Haglund's. A lot of professional runners have actually had the surgery to remove that deformity. I think most recently Galen Rupp did, and Gwen Jorgensen as well. And I'm sure that there's plenty of others out there. I mean, in terms of all of the other fancy treatments there are out there, all the other factors have to be taken care of as well. Proper rehab program, proper load and recovery time, nutrition, stress levels, sleep, all those other things I think need to be addressed and taken care of. And then we can add in like a PRP or an amnio if we're not getting the results that we want. Because I think a lot of the, if it's really just we can't get that tendon to remodel, those things can be helpful. But we have to look at a lot of other factors that might contribute to why it's taking a long time. Definitely not a miracle fix to use one of those treatment options.
No, and I actually like how you approach that because, as you know, my favorite thing is to talk about the entire athlete and to talk about how if we don't address nutrition and sleep and mindset, we are not really addressing the whole body and we can't get better with a physical injury. And so it's really just not possible. And I think that sometimes PRP or amnio or tennis, whatever it is, could be used too early or too often without the other things being addressed. Again, I bring it up because unfortunately our culture is not a patient one. And so when we run out of patients, we get frustrated and we just go right to those particular treatments, and they will not be successful if you're not really following the rehab protocol. So the other thing is if you're not following the rehab protocol first, they won't be as successful. But once you get those done, you have to go back and do more of the rehab stuff. Most of the physicians, which I really appreciate, say, okay, you can have PRP, but now you have to go back and do rehab as well. So you don't get out of rehab by doing the other things. You just actually probably end up with more rehab and you may have to start further back.
I think that's a great note to wrap it up, to address the whole athlete, the whole body. It's not just the Achilles tendon. So I hope that you guys enjoyed this lovely ride of information about the Achilles tendon. And of course, as always, if you have any questions, you can let us know.
Yeah, thanks for joining us. We really love doing this, and we'll talk to you soon. Thank you so much for joining us today. We hope that it resonated with you and that you learned something. If you enjoyed this podcast, please rate and leave us a review wherever you get your podcasts. It really helps increase our visibility within the platform so that more awesome people like you can find us.
If you'd like to support us further, pretty please, you can visit our Patreon page at patreon.com/morethanmiles. That's www.patreon.com/morethanmiles. Or for a few dollars, you can help the show grow and keep going, as well as receive exclusive perks like monthly Q&As with us. Until next time, remember to run the mile you're in, and that training is so much more than miles.